Hello, everybody. I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a great topic, one that has plagued orthopedics since the beginning of orthopedics and will continue to do so until the end of this JOEI session when we will come up with all the solutions. Fortunately for tonight, on this topic of wounds continue to fail. Fortunately for everybody, we have a guest moderator, once again, Anand Murthi. I'll introduce Anand. He'll introduce himself and take it from there.
Great. Thanks, Ira. Appreciate it again to moderate this awesome discussion on Joey. Got a great group of people on the chat site as well as our panelists. I am going to share my screen. Can you see that, Ira?
Yep, we got it.
This is a new, relatively new topic for me. I'm just beginning to learn about this platform and this industry. Um, the panelists we have on here, I think, are incredibly intelligent about it. So we're going to kind of talk about the problems that we have with wounds still failing in orthopedics and what we can do about it. Some options with patient optimization, wound care, what the problems are, how do we fix them, and maybe even some future innovations and options. This is our awesome panel. I'm going to have them introduce themselves. I'm Anand Murthi from Baltimore. I'm a shoulder and elbow specialist. And Nirav, you want to start? And then we'll go to Jeff
Sure.
and Michael.
Sure. I'm Nirav Amin. I'm an orthopedic surgeon. I did a fellowship in sports medicine at the Cleveland Clinic, and then I did a total knee fellowship in New York in Lenox Hill. So I have a little bit of a broad platform in my clinical practice.
Thanks, Nirav. Jeff?
Jeff?
Hi, I'm Jeff Lawrence. I'm in Wisconsin, and I'm a adult reconstructive doc. I did the Anderson Clinic Fellowship with Charlie and Jerry Ng, and my practice is primarily hip and knee reconstruction.
Thanks, Jeff. And Michael?
Yeah, hi, good evening. It's a treat to be on. I'm a big fan of IRA for many years, and I worked on a project with Nirav, and so it's an honor to be here amongst you guys. I am also sports trained 150 years ago, it seems like, but I did a fellowship with Andrews and Clancy in the 90s. And then while I still do a lot of sports medicine, I've kind of morphed into a joint guy after being in practice for 30 plus years. So I do a lot of knee arthroplasty and a lot of complex knees. Um, I still have a busy clinical practice, but I enjoy and have relationships with, I did for Yale for 25 years and now with Quinnipiac, which is a new local medical school. Um, I try to stay active and speak some at meetings, and I'm active in my state. That's how I first got to know Ira, where he joined us several times as a speaker at our Connecticut Orthopedic Society meeting. And I like to be involved some with industry and have been for years. I think it's important for us to hold hands, if you will, with industry and things that we believe in and can help our patients. We should help push the needle on that. So I'm grateful to be here amongst you guys and share this panel. I've listened to many of these webinars that Ira has put forth as well as his articles, and he's really been a tremendous mentor, I think, for many of us, and a wonderful guy and obviously a clinician.
Awesome. So this is our table of content. We'll try to get through problems, the market today, complications, some strategies to help improve our outcomes, because that's the whole goal we have today is and some of the clinical experience. I think Jeff's going to speak to that, and we'll go through some case examples too as well. So, this is the problem that I've learned. I had a run last year with some issues with wound problems and after shoulder arthroplasty, and we were really like just hitting our heads against the wall on how to help. And I was able to get involved with a local kind of trial with Bridge, which we'll talk about in a minute, and then delve and kind of studied about what's going on with the issues. Nirav, what do you see as being one of the major issues, at least in your practice or you've seen in your region and as you've been practicing?
Yeah, I think for me, on the realization happened in the Journal of Arthroplasty when there was an article talking about the reactions to Perneo and the wound complications associated with that. that kind of triggered a little bit of an alarm, to be fair, because I actually personally started seeing some of those reactions in my clinical practice. And my job in that setting and space was treating him with antibiotics, watching him very closely, and being very concerned, right, about the incision. On a total, anyone who's doing total knees, their biggest concern, outside of obviously interop concerns, is the wound, right, and getting that to heal, especially some of the patients who are anticoagulated pre-op, and then you're navigating that process as well. When I looked into that process, I started thinking about it, probably the same journey you had, looking into wounds and is there alternatives, right? So do I go to sutures? Do I go to staples? And then there's dressings that you can adhere that don't have that reaction as well on the market, that have a real value add perspective. And then I looked into applications. So I do a heavy amount of revision arthroplasty for my total knee side. And that's where the biggest concern came, right? So for us, on the revision side, there's a good level 1 study that shows a randomized clinical control trial with and without a negative pressure wound back. And the realization happened for me at that point was, well, if I want something that can decrease the amount of tension on my wound, then I'm mimicking what a negative pressure wound vac can do. And that's what honestly kind of brought me into the bridge world, is the unloading of tension at the surface level of the incision. And that was through some data that the CMO and founder Monty was able to share with me, looking at ultrasound imaging, looking at vascularity, and looking at that value add perspective really brought me into that fold.
Hey, Jeff, thanks, Nirav. Jeff, having the main, thing we see a lot is hip and knee, especially in the knee. Tell me what your real world issues are with wound care and wound problems and dehiscence, and when you walk into that patient room and you see that problem.
Well, hopefully you don't walk into the room and see that very often. The dehiscence part is devastating. I work in a rural area, and taking care of farmers is quite challenging because they're wonderful people to take care of because they all want to go back to work and they're very motivated, but they're also can be very non-compliant. And I've had several patients. I've learned to specifically tell them that I don't want them going into the barn for at least 4 to 6 weeks. And there's
Bob doesn't have that problem in Orange County. There's none of those.
yeah, probably not. But he's got to deal with 100-degree heat.
But Anand, I have the problem of them trying to go in the ocean water.
Yeah, that's true. All right.
That's the bigger problem.
Marinum, tuberculosis.
So inevitably, I have these hardworking patients who slip and they fall and they split their wound open and there's manure and all kinds of bad things around. So dehiscence is a tragic consequence, but fortunately rare. But the more common consequence is what Nirav was alluding to, are the skin reactions that you get, and it's become more and more. I think it's increased. And I spoke to the J&J people a couple of years ago at the Academy, and they had a theory that there was cross-reactivity between the hand sanitizers that we use and the components of glue, whether it's Dermabond, Prineo, Exif. And so I think it's increasing. And another really concerning thing to me is that you can't necessarily predict who it's going to happen to. And you could do a successful surgery. I also do a lot of revision surgery, and you can do a surgery on one extremity, and the person becomes sensitized, and you wouldn't know it. And then the next surgery, they have a horrible reaction to it.
Yeah.
And it can be devastating. I'll show some of my results in the study that I'll present in a little bit.
Michael, what's your journey been on wound care?
So I've been around a while, obviously, and orthopedics and arthroplasties changed considerably, and a lot of things have made real gains in technique and anesthesia and robotics, whatnot. But I think there's been appropriately more attention paid now to closure of any open wound, which is essential and shouldn't really be left, in my mind, to the resident or the PA. And then how you manage the limb over the next 3 to 4, even 6 weeks, I think has a tremendous impact in how well that patient will do, avoiding the catastrophes that come along with wound breakdown, obviously infection being the worst, but things referable to edema and the limb, clot, stiffness, all the stuff I think we'll touch upon today, and the ways in which we close all the layers, but the skin particularly has been something that is essential and brought attention to my practice, some of which I started with some other closures. And this new one, I think, is not just novel and quick and reasonable in its expense, but I think makes a great difference, as Nirav alluded to, in terms of tension. We don't want that skin edge to be ischemic. It used to be that I'd have 1 or 2 patients every month or 2 that I'd have to admit with cellulitis post-op.
Yeah.
And I think because of the things we're doing now with regard to the wound and the extremity, I can't remember the last time I've had to admit a patient post-op for cellulitis, wound drainage. And I also do a lot of complex arthroplasty and a lot of high-risk patients. And those are the ones you particularly have to pay attention to. So these type of closure methods are one of many things that I think we'll touch on today that are essential to good result and function, and obviously minimization of complications. So that the wound and the first 3 to 4 weeks are really, really important in my mind.
So these are some of the devices or platforms that are utilized, and they all have their kind of pros and cons. And I used to even use Staples, which worked. But I think we're really trying to minimize those outliers. We talk about infection or cellulitis or wound breakdown. Rob, what do you think the cost to the system is with something that happens like this? A complication, and why should hospitals and systems get involved with wound care?
Yeah, Anand, a great question, right? So it's actually, I think there's a direct and indirect cost when you think about that question, right? So there's a direct cost to the payer. So if I think about a closed loop network of the payer being the insurer and the provider, the medical provider, that's a cost directly to everyone within the health system itself. But let's say it's a commercial plan or a Medicare plan. There's an indirect cost too, right? So not only is it to the system, let's say it's a Medicare patient, but it's also to you as a provider, right? So if they have a wound complication, they're coming in to see you. Let's say you give them a PO, Keflex, 5 days. You want to see them back. Then they're actually burdening you. They're actually not burdening you. That's not the correct word, but they're coming into your office flow, right? That typically they wouldn't do. So they're taking up a slot in your visits. You're inconveniencing the patient now, right? From coming in from 2 weeks and then they're come back at 6 weeks. So now you decrease their work. You've changed their actual recovery patterns. You may slow down their physical therapy. So I think when someone looks at the hard dollar amount, it's very hard to quantify because we don't quantify all the details and minutia around it. So I think that's where it gets a little bit tricky. The slide that you had prior is really interesting, right? Because when we look at all those little devices and gadgets, they all have pros and cons. And I almost would say the bridge tissue should be to the right of the zip line, because the zip line in the reality was what the bridge evolved into, right? Is because we wanted something that created tension on one side and you close the incision. The challenge with the zip line became when you pulled on the other side, it created de-roofing on the subdermal layer, and we got a lot of blistering away from the incisions, and that's been our big concern, right? So we've all kind of gone in different spaces trying to see what layers help you get an optimal closure.
That's great. I mean, we talk about, I've had to learn using different techniques now, like how to actually close my layers. And, we have a PA and fellows and residents, and they have to learn. They come from different services and are learning different ways. And sometimes the closure, like Michael, sometimes that's left to someone who maybe shouldn't be or is not as experienced. But, I close a delto pec with, deep and then sub Q, and now I'll use the bridge or whatever for the superficial. And then put a bandage on top. Jeff, with a big high volume knee practice and hip, how do you close your layers if you want to get a couple of minutes to be granular about it?
Yeah, so I'll close my fascia layer with an O Stratafix. So I run that, and then I try to close the dead space with a 2O Stratafix. Then I'll use an interrupted 2O monocurl plus, and then I'll run a 4O subcuticular. And then in my previous life, I was using a glue product, and now I've found Bridge, and I use that routinely over that. Then I put a Telfa and a Tegaderm over that. So that's been my closure, and it's worked well.
Michael, how about you?
Yeah, some of what Nirav said, I think is true in my practice. I started years ago with Staples, went to a subcuticular, but I think that subcuticular can be dangerous too if you devascularize that edge. And so I used the zip line for several years and liked it, but it is a bit fussy. And you can have allergic reaction to it, and it has to be done carefully where you don't overtension. I like this bridge because it's so facile to use and because it is predictable, and it avoids the things that a subcuticular can cause. And I still use a lot of suction, Pico, Provena, what have you, for the high-risk patient if they have advanced deformity, they're morbidly obese or unstable diabetic. So I use these suctions probably 10 or 15% of my cases. But I like this because it's quick, it's easy, and I think you get the same result, and it's well tolerated by the patient. You know, it used to be Staples. They hated having them under their dressing and bending their knee. There's tremendous tension on the knee, the total knee, and so I think this has a real advantage, and that's why I have adopted it.
Hey,
So,
patients, I was just going to add on to what Michael said. Patients like it. I mean, they
Yeah.
really do. First of all, I think it makes a much more cosmetic closure. I think the wounds look better than anything I've ever used.
100%.
And patients, they feel like there's a little protection against clothing, against bumping things, and it comes off easily. It doesn't hurt at all. So I think it's been a win-win for us and for patients.
Jeff, and I'll piggyback on that, right? When you think about like using staples for my historical norms, there is a true kind of train track appearance if you put the staples down in line, right? And cosmetically, I know our outcome is important, but cosmetically, patients sometimes will not like the cosmesis of that. So
Sure.
I think this adds a real value add. One thing we've seen in our clinical practice in the total knee side, and I don't know if the panel has seen this, and I don't know if you've seen this a little bit, not maybe in the upper extremity side as much, but we've seen a lot less swelling at the incision side when we've closed it with bridge comparative. We've tried to think about ways to quantify that from a study standpoint, but the swelling in the incision and the overall, like,
Do you
Andrew
think that's
Woodline.
because of improved perfusion? Do you think they're getting better circulation, better drainage, lymph, you know?
I think so, Anand. I think if you actually look at the scientific like platform of the version of the skin and vascularity going in, you're not having the actual inflammation as much, right? Because in reality, I think you showed a slide a couple of slides ago, right? If you do a subcuticular, like one thing that's been studied well about quill sutures or Stratafix, if you let's say use a 2O in the fat and you pull as hard as you can, you actually strangulate the fat and the vascularity in that region. So it's a very delicate technique. I think we're all used to it now. But when you
Yeah.
even run your 2O and your Fowler, you approximate it. And the residents, when you have young residents, they just want to pull, right? As tight as they can.
Yeah.
So I think there's an art to it. And I think the one thing this does, is it helps evolve the vascularity. So I think it helps kind of the return of the vascular flow and so forth a little bit better.
So as we're talking about just perfusion and healing, I want to give a couple minutes to talk about how each of you in 26 are doing patient optimization with regards to nutrition, pre-op, post-op care, with regards to nutrition, patient optimization. Myself, I put them on a protein program, fluid program, nutrition program. We try to, make sure diabetics have, proper A1C, those kind of things. How about you, Michael? What do you do for patient optimization? I'll give you a minute for that.
Yeah, all of that, Anand. And I think it's important that the patient is vested. And I tell them that out of the gate, that this is a shared commitment, theirs and mine. If they're morbidly obese, I ask them to demonstrate to me that they've lost a certain quotient of weight. I don't necessarily have as hard a number. I like them to be under 40 BMI. If they're smokers, I want them to, if not stop, certainly slow down. I think alcohol is overlooked and very important. If they're big drinkers, the risk quotient is considerably higher. But recognizing lymphedema and stasis, all those things are essential with nutrition, low sodium diet, getting them ready for the operation. And if they're not ready, I won't do them. And that's, I think, part of the maturation I've had. I used to have a little bit more hubris than I do now and realize, as I've been taught by a lot of people that I respect, that, you never regret a case you haven't done, only those you have. And if
Right.
they're not suitable, and I'll get clearance from all the specialists, including vascular surgeons, but they have to show a commitment that they understand and want to get well and optimize themselves. And if they can't and they don't, um, I'll tell them they have to go somewhere else, that I don't feel comfortable. It's not a shared thing. So there are a lot of things, and we can touch on some of them later, the specifics, but it's a big deal to get ready for an arthroplasty. It's a hard, long recovery. And if you have any of these complications, it's a catastrophe. God forbid you get an infection. Not only is our life miserable as the physician, but the patient's life is changed potentially forever. So I think those details that we now look at pre-op as well as intra-op and post-op are so important. And I think we're appropriately spending the time and attention there.
Nirav, you want to talk about, you began to talk a little bit about removing tension on incisions and the swelling. Can you talk a little bit about how we can do that with Bridge and some of our newer devices?
Can I
Yeah.
just add one thing to what Michael
Yeah,
said?
Jeff.
I do everything that has been talked about. Also, tobacco wasn't mentioned. I think that's obvious, but we've all learned to avoid that. Vitamin D is another thing to look at, and that's become a popular concern. But lymphedema, I think, is a really important one, and Michael touched on it. But anybody that has pitting edema, I make sure that they're going to occupational therapy pre-op, and they can do really remarkable things in terms of milking the fluid out, and then exercises that they can do, and compression garments. And if you can control that fluid level, I think you have a much better chance of having a good wound after surgery.
Yeah, and Anand, you asked the question about nutrition, right? Raja Jaswari has done really nice work on pre-optimization, right, of nutrition. He's done a lot of research in that space. Um,
Huge.
I think the challenge is, right, in reality, I think all panelists would agree on this panel, that you wouldn't be able to optimize a patient in any manner. I think we'd like to, if we could, but sometimes the insurances, the financial ramifications don't allow them to get to that state. So then we have to mitigate those by ordering our pre-albumin and albumin markers to see their kind of health status and initial status on that setting. But I think it's really important on, and you hit the nail on the coffin. If the patients go into surgery in a suboptimal setting, we're kind of fighting everything against them, and that's uphill. And that's what gets into the tensioning, right? Because if they are a smoker, if they are diabetic, and they're slightly obese, they have every risk factor, and let's say they financially can't afford the pre-optimization for nutrition, then we're looking for ways to mitigate or reduce those catastrophic complications.
Yeah, we got to take care of worst case scenario because they're still going to have surgery, a lot
Yeah,
of
at
these
the end,
things, right?
yeah. And then the sad part is, right, I mean, I think as you alluded to, sometimes like you want to try to do everything you can. And I think that's where the tension on the skin becomes so important, right? I think as you alluded to earlier, that you went back about 18 months ago or 2 years ago and started looking at this a little bit in detail. That's the same thing that happened with me, right? I just put a negative pressure wound vac. Mike, you
Yep.
were saying use a Pico 10 to 15% of the time. And that's the same thing I do, right? I use a negative pressure wound vac. But then again, underneath those, I would put staples on, right? Because that was my concern. So I was looking for a way to have the best of both worlds of untensioning it with having vascularity, with the negative flow. And that's where I kind of came to the bridge solution.
That's great. That's great. So, we talk about the landscape today. We have different types of closures and used in different types of formats. And even you guys are saying you're using different closure techniques for different situations. So there are steri strips and silk. There's closed incision, like the Pravina and Pico. We've got detensioning devices, zip line and Closex, and then we have the bridge, which is active tension offloading. Um, Jeff, do you want to talk about, how that works biomechanically and how you're changing the tension? You can almost see it in these photos where you have a little bit more, vascularity in the midline and off tensioning it laterally.
Yeah, it's really a brilliant invention, to be honest. It's kind of the opposite thought of what you see athletes that wear on their noses that try to tension the other direction to open up your airway. So it's put in preloaded, like you see on the far left, and then it sits across the incision with an adhesive that is inert and brings the skin edges together and creates like a mohawk type of effect along the incision. And so it does the opposite of tension. It applies compression across the incision, which I think augments blood flow to the area and helps with healing. So it really mechanically provides something that we can't do otherwise.
That's great. Is there a case where you think even in revision settings we can use this type of stuff, Nirav? What do you think? Instead
Yeah,
of
I mean,
holes or
uh,
things like that.
yeah, great question, Anand. I think I think that's twofold, right? Number one, in the revision setting, obviously the concern goes up even higher for the incision, right? So for me, in the current setting in space, right, I do the routine closure that I do, and then I add a bridge, and then I add a negative pressure wound vac on top, right?
Got it.
And so that's my current environment. Now, is there a roll down the road, potentially, right, where there's thoughts of potentially where there's an adhesive called a seal coming out in next quarter,
Hold
right?
on, hold on. We'll get to that in a minute. Don't
But
jump
but
far ahead.
but but on it, to be fair, I think there is a potential, right? And again, I don't want to jump the gun, but I do think there's a potential, right, to potentially not need a negative pressure wound vac, which could be a huge cost savings to the systems, right? But again, that would have to be proven out clinically.
And also potentially just less subdermal closure needed as well. So you're talking about a
Oh
time
yeah.
time savings issue. So we're going to get to this clinical trial update. I reviewed a little bit before tonight. Exciting stuff. Jeff, you want to take us through your study? And
Yeah,
I'll
I'd love to. I'm really excited about it. Uh, so just a little background on how I got here. I had so much difficulty using glue, and I wanted something. I really wanted something that was going to seal the wound, and and at the same time a different adhesive that wasn't going to be so reactive. So I dedicated my time at the academy 2 years ago trying to find something other than glue to close, and I went through pretty much every single booth at the academy, and I found
That's a
bridge.
lot of boots. That's a lot of boots.
Oh, absolutely it is. But I was determined I was going to find something, and that's how I found this product, and ended up spending a lot of time talking to them. And so I agreed to do all of my cases for a week, and then I waited 6 weeks to see them back in the office and see how they did. And I was so impressed with how they did that then I committed to doing all of my cases like that. So that's how things evolved in my practice. And so after I'm 2 years in now using Bridge, and my biggest concern using it was that it didn't seal the wound, which Nirav was starting to allude to. And would that be a problem with drainage? So I'll talk about that in a minute. So we, with this study, we looked at my last 100 glue cases, and that includes Dermabond, Exafin, and Prineo. Most of them were Dermabond. And then looked at my first 100 consecutive bridge cases. And my closure was standardized between both. That didn't change. And we had four reviewers, two junior reviewers and two senior reviewers. And so the first junior reviewer looked at all of the cases and identified anything that was a wound event. The second review, and then she blinded all of the data. The second junior reviewer then looked at them to see if that person agreed or not, and any discrepancies were then reviewed by the senior reviewers. And then we created, and then we decided whether it was an event or not. We created 5 wound healing categories. So skin reaction, SSI, delayed healing, fluid collection, bleeding, and then stratify them by level of severity 1, 2, and 3. So like for skin reaction was a rash, level 1 would have required topical steroids, level 2 would have been oral steroids, and a level 3 would be returned to the operating room. They'd be the most severe. And in this situation, they were both septic joints that started as a rash. The SSIs, level 1 was minor in observation. Level 2 would have been oral steroids. Level 3 would have been returned to the OR, and those were septic joints. Delayed healing would have been like serous drainage. So less than 72 hours was level 1. 72 hours to a week would have been a level 2. Might have put a wound vac on that, certainly a dressing change. And then a level 3 would have been a return to the OR. Fluid collection, so seroma or hematoma, level 1 observation, or if it was a hemarthrosis and aspirated, would have been less than 30 cc's. A level 2 greater than 30 cc's, and again, maybe a vac put on, and level 3 return to the OR. And then bleeding, again, less than 72 hours, maybe a dressing change would have been level 1. Level 2, greater than 72 hours to a week, and level 1 return to the OR, so evacuation of a hematoma. Any drainage greater than a week was an automatic return to the OR. We didn't have any in this study. So if you go to the next slide, you can see that with glue, we had, well, with bridge, we had a decrease in level 1 events of 72%, level 2 events 75%, level 3 events return to the OR of 100%, and 100% reduction in allergic reactions, no PJIs, and if you take the allergic reactions out, still a decrease of overall events of 54%. So it's a pretty impressive difference between the two cohorts. Yeah.
Great. Are you continuing this out for long? So how long is the longest follow-up on yours now?
So the longest follow-up would have been with the glue cohort, and that would have been now probably 3 years ago. The first year of bridge was a year, would have been 2 years ago to a year ago, and so we looked at that time period. We're going to start a prospective series using SEAL, which we're going to talk about in a little bit, which I'm looking forward to.
I mean, you talk about no PGI and drainage and return to OR. These are huge savings to the hospital system. But to me, it's a great biggest impact is on the patient. And, the patients are our currency. And so, having them have a better result and happier and better customer service is a huge deal. So, Nirav, I don't know if everyone on the call even knows who SEAL is. Unfortunately, I do. So SEAL or no? So I know you were about to broach this new topic, which is pretty cool. Do you want to take us through this new device that's going to be coming out and in conjunction with the bridge?
Yeah, great, Anand. So this is a total knee that I'm doing. So the knee's flexed to about 70 degrees.
This is real time. This is not slowed down either. Or it's not sped up.
So basically, this is you could see the difference, right? So soon, I think Q3, hopefully out to the market, is the idea or the goal or the time print. I think the one illusion that Jeff alluded to earlier is when you first use the bridge dressing, the one concern you have that is I've been asked openly is, hey, there's no actual seal to the outside barrier, right? So when I'm walking or so forth, they could have oozing or something through the bridge stack itself where you're putting on. And that's where this to me was kind of the light bulb went off, right? So if I can put a sealant on the incision, and the sealant is not like our typical Tegaderm. It's actually got a different adhesive that actually expands and allows breathable areas. So you don't have that Tegaderm type feeling that you do on a total knee that we're used to. We put a 4x4 or Telfa over the incision, and then you get this kind of skin blistering at the edges. So not only is the seal have the special coating underneath that allows it to extend and flex through the knee range of motion, you can see actually as the bridges go on, you can actually see the inversion, as someone alluded to earlier in today's call, the mohawk appearance. And that's what you want, right? You want an incision that is having untension on the sides and tensionless healing potential where you've made your arthrotomy and skin incision through. And to me, this is kind of where it's going to lie. And this is a real value add. I mean, Anand, can I tell you one thing that I think is going to actually be a huge value add in this space is going to be in the geriatric population when we do hip fractures for hemis and nailings. Because what I think a lot of us underestimate is that a lot of those patients, when they're in diapers and so forth, they're laying in their incision. And sometimes the nursing staff is not as quick to change the diaper. And when you get, and when you get an E. coli infection, right? E. coli comes from the urine, and when it's on your hip incision, it often is from the spot where we're thinking it is. So I think that's where the real value add is going to come, because you could see how well it clears up. And the one thing is, hopefully my hand will move out of the way. You could see the actual incision oozing just a touch, just so you know the tourniquet is down here on it. So the tourniquet is fully down. You could see the oozing, but you could see how well it seals it up. And it actually doesn't elongate and track in a spider manner like our tegaderms. So real value add here.
So 2 questions for you, Nirav. Are you putting anything over the bridges? Are you putting a TELFA or anything in addition to this, or is this your whole closure?
Yeah, so on this setting, right, I won't put anything on top, right? So I will tell the patients that this is their dressing, and I tell them that they can shower the next day. So the one thing that you do
question they ask, right? It's a big question they all ask is, when can I shower?
Yeah, huge. And Anand, the one thing is, right, something that can alert you, like this gentleman is a perfect example, right? This was a reverse that I did, right? He's a great example. You could see a little bit of the bleeding as you put the seal on, but you could see his incision 2 weeks later, and you could see, I mean, it's fully healed in. It looks very like there's no elevation of the tissue. And then the one thing I have realized is, if you're not putting anything on top, you should tell the patient that, like, this is the new dressing you're putting on pre-op, because otherwise they get a little bit concerned, like, hey, these clips is draining, and they'll call your office. It's just something they're not accustomed to. They're accustomed to their knee incision being covered with all kinds of ACE 4x4s and all kinds of dressings on top.
Michael or Jeff used the seal also?
I have not been able to use the seal yet. I'm hoping to have it in my hands next month. So, right, money.
No pressure.
Nirav, do you? I have one more question for Nirav. Have you dropped your subcuticular closure, or are you still using that?
So if I'm going to use the seal, I no longer want. So my closure on a total knee is I run 5 figure of 8 an active braid in extension. And then I put the knee to 90 degrees of flexion, and I run a number 1 Stratafix. And then I run a O-Vicryl for the subcuticular fat layer. And then I close my sub-Q with the 2O monocryl. And then I used to run a 3O monocryl. Interrupted. Yeah. And then I used to run a 3O monocryl on top, and I've dropped the 3O layer. And Jeff, I've timed my PA, to be fair, because that's who does the closures. So the last 13 knees he's done, he's timed his 3O running layer. Then it's anywhere his fastest is 4 minutes and 11 seconds, all the way to 6 minutes and 13 seconds. So there's a real value add of even dropping that closure in that layer. And to date, again, and this is
well, you add that up over 6-7 cases, it's an hour, right?
Or it's a real time.
I mean, you could add another case.
You can either get to the beach or another case.
Or on, and you get to the 3 o'clock witching hour at the hospital where no one wants to work.
But that's 100%. 100%.
Hey, Anand, it's Kevin Blanchard.
Hey, Kevin.
Hi. First, I want to thank you for leading this great conversation. I wanted to say I was tortured before doing all these total knees as a hand and microvascular surgeon. And I think the plastic surgeons have taught us a lot, and sewing arteries and veins. So I want to thank Bridge, because we know that it offloads, and they have great study, as Jeff has shown, and Anand, as you've shown, and Nirav. But I have to say that I think they've also shown that you don't need to add this vacuum negative pressure, because the studies have shown they are just as effective. So I encourage the panel to think about not doing the belt and suspensors and getting rid of that negative pressure that costs $700 or $800 per case. And I think they've really gone on to things. And whether You do, and Rob doesn't want to do the subcuticular. I think it is how we approach the tissue and how we hold it. And we weren't taught that as orthopedic surgeons in my fellowships, but rather the plastic surgeons have been doing this for years. And the showering
100%.
that
100%.
you say, they believe at 5 days, even in total knees, they were always saying, "We're done."
Yeah.
And yet we were always taught, oh, 2 weeks, stay away from it. So I think we're moving to that. And Bridge has really found their science. And I encourage people to look at what they're doing, people like Jeff and others, that this offloading the tension is the key. And they figured it out. And it's exciting. It's really exciting.
As you say, I'm just learning about this. We never got trained in this, we just did
Right.
statements, right? And the amount of people you can save,
Right.
you save one patient, a year with a skin problem or a wound problem, it's a humongous. I know it's a savings to the hospital and cost, but I'd rather save the patient's outcome too. Thanks, Kevin.
Anand,
Michael, take us through this case, Michael.
So, as Kevin pointed out, we learned from other subspecialists. Kevin and I learned about partial knees from Rupici, who was a dentist, and brought then that to partial knee arthroplasty and this technique from a plastic surgeon. And I think it's important to pay attention to other disciplines to absorb and learn and go forward. Anyhow, this is a patient of mine that we just saw. That she was a high risk woman on steroids with MS and a bunch of comorbidities. And it shows that it's a facile thing to do. It doesn't take long. It probably saves on maybe what did Nirav say, 4 to 6 minutes, but in my OR, probably 9 to 10 minutes. The closure, if it's done by a PA, takes a long time. So this saves time and money. I think it's very gentle in the high-risk population. And a lot of my time and attention was actually at Kevin's meeting 4 or 5 years ago. I was on the podium with Andrew Wickline, and I quote his article in the next few slides. And he paid attention to, as I do, the perioperative edema. And I just, most of the stuff we've talked about already, so we can go through it quickly. But lymphedema can be measured, and it has to be appreciated pre-op. And you have to do simple things too. Go to the pre-op slide, sorry, first. You want to stop vasodilating medicines, and we mentioned all the other optimizations. So we can go through that, but having the patient conditioned, this is on the right side of the slide, is also very important. You want the patient to be fit pre-op, good motion pre-op, to do well post-op. And then you can go to the next slide. I elevate my patients for at least 12 hours if they have any edema before the surgery. Intra-op TXA has really changed the equation, I think, for bleeding. And I use it both IV, topical, and then, as Andy Wickline taught me, I use it orally for another 14 days. So if you stop a lot of bleeding, you stop a lot of edema. I mean, you have to have some inflammation. It's important, but you don't want it out of control. And I don't use a tourniquet. I think that also participates with swelling. You got to be really careful with your tissues and your dissection. I close, as Nirav just said, in flexion. I use the bridge, and I still use, and I think it's important, although it's costly, as Kevin mentioned. In the very high risk patient, I think negative compression dressing is worth it, at least in my mind. And then important part of this is resting the limb. So for a few weeks, I don't do a lot of therapy, and I keep the leg elevated at least the first 7 days for the most part, except for bathroom and dinner time. And if you let the edema subside in that first week or two, the whole post-op course is easier, and you have a careful PT program. The elastic stockings are very important, as is cold compression. And all these things combined with this novel bridge closure, I think, lessens all of the perioperative things that we all hate and worry about, infection and wound dehiscence. So that's just a quick, really a summary in part of Wickline's inflammation tsunami, which he popularized. And it's a wonderful article. And I encourage everybody on this call to read it if you haven't. He's really one of the most important players in this space, and now with the lessening of and need for narcotic, which is another big and important push he's making. So
Awesome.
that's my 2 cents.
Appreciate it. These are, as we're getting close in, these are my kind of initial uses of bridge on a delto pec. And, for me, it helped with efficiency, reproducibility, cosmesis, and, less phone calls to the staff and office. And, we let them keep it on as long as they want, especially for some incisions at risk. And I think it's really, my PA who's been with me for many years is finding it really cosmetically nice to use as well. So,
Yeah, Anand,
um,
if you go back and show that picture one more time, if you don't mind. I find that the most cosmetic and the incision overall is very cosmetic, but even if you drill down more granular way, the place where the bridges actually are is even better than the area in between, which to me reinforces how important compression is and taking tension off.
yeah,
Because it's pretty remarkable the difference between where the bridge is and isn't. It's kind of a variegated incision, but it just I think reinforces what we're all talking about.
yeah. It's been, when you're busy and you have a lot of volume, it's really, this part of the closures we've talked about is, closure, if you can save time as well, time is money, OR time is really expensive. And I like it to be efficient and reproducible, especially when we're training fellows and residents as well. So, as we get to the end, um, we'll check the chat side as well. But I just want to give our panelists first, thank you, but some time to kind of add their final thoughts on wound closure, dressings, patient optimization, and what you see happening in the future and what you'd like to see for your patients. Nirav, I'll start with you.
Sure. I think Kevin Blanchard made a great point right on this early on. I think one of the things that I haven't mentioned yet is one of my draws or attractiveness to the bridge as well was the utilization of it through the plastic surgery side. So it is very well adopted in plastic surgery, especially in Orange County and high populous areas. So your thoughts are if there is a surgeon who cares about the cosmesis of an incision, it's absolutely a plastic surgeon whose livelihood is dependent on that. So if they're comfortable in that setting and space, it would tell you the comfort level they have. And so if you can translate over that into our setting and space, there's a real value add as well, right? The second aspects that I would tell you is I think as we evolve through the process, because of the changes, right? Because of the traditional glue to the toxicity levels that have now been discussed with Perneo, to the silk, which has a real value add in a dressing on a simple incision that you can put on. And then this is the added benefit of offloading the tension. I think Kevin mentioned the reality is yes, should there be a randomized control trial to compare the seal and bridge versus a negative pressure wound vac? I think that will be the first steps that will take place. And I think we have to prove that out, right? That it can actually be safe for our patients to actually drop the negative pressure wound vac. But yes, is that our hope? Yes, that is our hope because we can save the system financial financial costs and give our patients the same outcome that we're hoping to give. So I think there's a double-edged sword that we're trying to navigate through.
Awesome. Michael, how about you?
Yeah, I'm not as familiar with the seal. I'm excited about it, and for the reasons we've already cited. I think you can still use a bridge with glue, and you can still use it certainly with a negative dressing device should you choose to. I don't think they're exclusive. If you can get something like a seal that has tremendous opportunity in my mind, I'm not familiar enough with it personally to support it, but it makes intuitively a lot of sense to me. And I think you have to be open-minded even after you've been around a while, as Ira and Kevin and I have, to be open to these new things and listen to our colleagues. And this is yet another way in which we can serve our patients. Lessen cost, of course. Cosmesis is very important. That's what they see, and they look down on their wound. And I was taught years ago, if you have to enlarge the incision, do it on the distal side because they don't see it when they're looking down at their knee and their knee is bent. And it sounds a little silly, but that's what they come home with, the wound. And so it's important it looks well. Obviously, it's important it doesn't get infected and have dehiscence. But this is, I think, a wonderful addition to our armamentarium, and I'm grateful to have it.
Before I finish with Jeff, there's a question. Maybe Jeff can answer. Is this a hard plastic material? Would you use it on an anterior approach hip where there was a fold inflection at the lap? Jeff,
Um,
I don't know where the hip is, so you're gonna have to answer.
Well, I'm also an old guy, and I'm a posterior approach guy, so I can't speak from personal experience. I think it would be challenging to use it across the hip flexion fold because it would work against the compression of the device, and it might pop off if you're putting it right across the flexion crease. And you might use a hybrid and close it all the way up to that one area and then use something else to close the skin. Either just put the seal over it and not use a bridge in that area because it's a pretty small area of your incision, but I
Yeah.
think it would be a challenge in that particular area.
So why don't you finish us off? I believe in all what we've said, but I think we need to follow this with research. I believe in research and outcomes and following things out and seeing how they happen. We're going to do that with Bridge. So since you've done such a great study, can you finish us off on this wonderful webinar on what you plan to do in the future to follow these patients?
So in terms of the cohort that I described, they're out far enough that if they were going to have wound problems, we would know about it, right? So I think that they don't really need any additional follow-up, but I think continuing to look at what we're doing critically. So exactly what Michael was talking about in looking at what happens with seal versus closed suction, and also what happens when you drop the subcuticular layer. Is that something that we can do safely, consistently? Is it going to lead to more wound problems? I'm very excited about that possibility because of the time saving aspect of it, as well as just we do know that that causes more skin necrosis. You see little suture granulomas and small openings that all potentially could become bigger problems if we can minimize exposure of our patients to those problems. And that's a huge
Yeah.
change for us. So all of those things are really exciting and what we can do moving forward. So I think this has been a great discussion. I appreciate the opportunity to share what we're doing with all of you, and I think the future is bright.
Appreciate it, Jeff. So, I use it in the shoulder. I use it in the elbow. I started using the elbow the last couple of months, and it allows them to rehab even in their, after Tommy John or distal biceps pretty early without any issues. So I think that's an added advantage as well. So I appreciate everyone's opinions and conversation. Ira, how'd I do? I gave you a minute back. Everyone gets a minute extra. Nirav gets to hit the 100-degree heat a little earlier.
Yeah, huh?
Um,
Great
it was a
job.
great talk. Appreciate everyone's
Great
time.
job. The fastest hour in orthopedics, I like to say, even faster when I don't have to moderate it. It's it's good when you're having a good time. I want to thank everybody, the panel members, and all the participants. We have other JOEI webinars coming up throughout the year. We will try to get on and to moderate every single one of them, even the ones on toe hard
Nose,
corns.
um,
Anything, yeah,
yeah,
anything we
nothing
can do.
wrong with a corn.
Nothing wrong with a corn. Anyway,
Anything but spine. Anything but spine.
well, I'll say good night. And Nirav, would you get some of that temperature in Southern California up to the
Send it east.
Northeast?
Send
East,
it northeast.
bring it
Try
over,
it.
man. Bring it over. Thank you, Michael. Thank you, Jeff. Thank you, Nirav. Anand. Anand, thank you.